The occasion allows us to discuss the possible updates in management of T-cell malignancies that comes from the update of the latest WHO classification from 2017. And I'm going to select some specific entities which represent the main news within this kind of update. So the first one will be the TFH lymphoma, so-called T-follicular helper cell derived, identifying with more precision what is the cell of origin of these tumors. It is the T-cell helper cells that derives from the follicular germinal centers in the lymph node, and that's why they are called T-follicular helper cell derived lymphomas. Of those, the main entity, the most important and the most well-known entity are the angioimmunoblastic T-cell lymphomas. And we understand now from the biology, which goes deeper into the genome and the genomic alterations of these tumors, that they have some mutations in the so-called epigenetic modifier genes that so far have been mostly known in neoplasias, in cancers of the myeloid system, so acute myeloid leukemias or chronic myeloproliferative diseases. So it was an interesting discovery to see that these same mutation, the mutation in the same genes, were not specific for the myeloid diseases, but also are encountered in a clustering fashion in these rather rare T-cell malignancies. Another group of entities where there are interesting news for those that work with T-cell malignancies are the T-cell lymphomas of the gastrointestinal tract. Most important is the change of terminology that the WHO committee, with the advisory from the Clinical Advisory Committee of the WHO, recognizes now that what was called type 2 enteropathy-associated T-cell lymphoma needed a change of name because these were patients, or are patients, that do not have any sign of enteropathy. So it didn't sound very logic for those working, the health workers and also diagnostic people, to call something, and clinical workers to call something for what they do are not. So not being enteropathy associated, the name enteropathy associated type 2 has been removed, and now they are called according to some histological and immunophenotypic features, and the name is abbreviated MEITL, monomorphic epithelial intestinal T-cell lymphomas. These are tumors that are mostly of CD8 cytotoxic immunophenotype, often but not always express also the NK marker of CD56, and are, epidemiologically speaking, more frequent in people of Hispanic and Asian origin. ALCL is the third group of entities, if you want, that has been updated substantially. There has been a move of an entity which was provisional in the previous WHO classification to a definite entity, which is the anaplastic large cell lymphoma, ALCL, that does not have the fusion protein ALK. So we call them ALK negative ALCLs, as opposed to those that have the fusion protein, mostly seen in children and young adults, called ALK positive ALCL. So the ALK negative are now a definite entity, no longer a provisional entity, and we know now more about their genomic alterations. For example, that they often have an regulation of an oncogenic pathway, the JAK-STAT pathway, with mutations or fusions within this pathway, in genes of this pathway, which is interesting also from a therapeutic targeting point of view. Then there is an entity within the ALCL which was not recognized in the latest classification, but has been recognized in the years between the latest and now, which is the breast implant-associated anaplastic large cell lymphoma. This has been described now in several cases which accumulate through, although still a very rare entity, it can develop in women that have breast implants either for cosmetic reasons or for reconstruction reasons after breast surgery for breast cancer, for example. And the lymphoma occurs in most of the cases rather localized, just around the implant, with a seroma-like presentation. The seroma is within the capsule that is developed around the breast implant. And in the fluid there are the lymphoma cells swimming around. So the primary recommendation is the surgical removal of the implant, but in some rare cases you also can see dissemination of the case, which then requires a more intensive therapy consisting of chemotherapy and in some cases also transplant. But that's only limited to a very small number of cases. The large majority, the bulk of cases, is the surgical removal once you have done the diagnostic on the cells from the fluid of the seroma. And lastly, there is now from a very large global clinical trial called the Echelon-2 trial, a company-initiated trial from Seattle Genetics Takeda, that found for the first time an improvement of outcome. Progression-free survival was the primary endpoint of the combination of a targeted antibody conjugate, the anti-CD30 conjugate with vedotin as the cytotoxic molecule called brentuximab vedotin, or Adcetris with the commercial name, combined with the chemotherapy backbone CHOP, which has improved outcome for patients with CD30 positive peripheral T-cell lymphoma. In that study, the bulk of patients were anaplastic large cell lymphomas, where we can see the greatest benefit of this combination.